So a metaphor for healthcare funding that I'd like you to think about it is the onion, because from the outside, healthcare can look a bit chaotic and unorganized. But if you take a closer examination, you really find a system that is built on 100 years of incremental legislation and funding models. And something our country is really good at is passing laws without eliminating sort of the sins of the past and what have we learned. So we just have laws on top of laws on top of laws and make minor adjustments with amendments. And so the onion is a great example for how healthcare works today. So I'm going to take you through a 100-year history in about 15 minutes here so we can talk about the business models in healthcare and how they actually work. So let's begin at the turn of the century of the 1900s when organized medicine actually began. This was the very first time physicians began to band together to create a trade association for themselves. And they formed the American Medical Association in 1903 to become a powerful influence in healthcare legislation even today. We, at the time, did not have anything going on in Congress about legislation of health insurance whatsoever, whether that was how physicians were organized, how hospitals were organized, or even health insurance. So the very first momentum in the earliest part of the century was simply physicians choosing to organize and share some of their thinking with one another. In the 1910s, Theodore Roosevelt endorsed this idea of social insurance as part of his platform in campaigns then on the issue of mandatory health insurance, which is supported by many progressive groups in 1912. Interestingly, that same year, the National Convention of Insurance Commissions develops and forms the very first model of a state law in regulating health insurance whatsoever. So this is following about 6-7 years after the American Medical Association forms. Also, the American Association of Labor Relations publishes a draft bill for compulsory health insurance and promotes campaigns across a number of states. Their efforts are set aside at the beginning of World War I and would have to wait a generation or so before things started heating up again as an opportunity. In the 1920s, the cost of healthcare becomes really interesting to lots of players relative to other sectors, and there becomes a trend of healthcare costs increasing higher than the consumer price index. So medical attention becomes increasingly more difficult for the middle class to afford because most individuals, like 90-some% of people, are paying out of their pocket for their healthcare because there is no organized way to pay for your healthcare yet formed. Politically, no changes were made to healthcare law, but some companies such as Baylor University in Texas began to offer health insurance to their employees in 1929. And their prepaid health insurance is the forerunner for the future nonprofit Blue Cross plans that emerged across the country. And 29 was also the year that Kaiser was formed. Now, a couple of things to note about Blue Cross and Blue Shield. We often see those as synonymous today, but they actually individually formed. Blue Cross was formed to pay for hospitalization costs. Blue Shield was formed to pay for physicians. And at the time of their formation, they were completely separate entities and were not part of the same organization. Over time, they have merged in some states, but not all states. It's important to know that the very first form of insurance actually covered hospitalization, but did not cover physician fees at all. In the 1930s, Blue Shield was formed, and it was done in conjunction with the American Medical Association, and it was to now cover physician fees. So if you want to think about the Cross and Shield and how they work, Cross was formed for the coverage of hospitalization. Shield was formed for the coverage of physicians. That was also a year where they began some joint marketing in states where they wanted to work together or eventually merge. The Great Depression brought an emphasis on offering government-based benefits to Americans. However, in the passing of the Social Security Act of the 1930s, health insurance was omitted again, largely because the American Medical Association had voiced such strong opposition to any health insurance program, fearing it would limit doctors' freedoms. And as Blue Cross began to expand outside of Texas, so did Blue Shield begin its expansion. And suddenly we were getting to see the Cross and Shield move across the country and a number of states. Now, it's important to recognize the origin of both Cross and Shield. Blue Cross, in combination with Baylor University and Baylor Hospital, was formed in partnerships with hospitals. Blue Shield was formed in partnership with physicians, and some threads of that partnership still exist even today, which is why I pointed out to you. During the 1940s, World War II created an incentive for employers to suddenly begin to offer health insurance. And it was largely driven by the wage controls that existed during World War II, because wage controls were set across all industries in the US for the war effort. So the only way an employer could offer anything of difference beyond wages was to offer benefits. And one of the benefits employers began to offer was health insurance coverage. So this was the very beginning employer-based health insurance that we have today. And it was driven as a byproduct of World War II and wage freezes and employers looking to offer some point of difference so they could attract employees. Now, President Truman proposed a nationalized health care system that included mandatory coverage back in 1945 at this height of war. It was ostracized by the American Medical Association, whose members deemed Truman's plan as socialized medicine. And so the American Medical Association had a big hand in defeating President Truman's plan to give health insurance to all Americans. Another important thing to note, particularly any of you who are from or live in rural communities, is the Hill-Burton Act of 1946, which was the last major piece of legislation to fund hospital construction. And during the late 40s and early 50s, hospitals were built all across America in small and rural communities through the Hill-Burton Act that provided federal funding to do that. It's one of the reasons you see in many small rural communities, hospitals whose infrastructure are either very old or they have been converted to outpatient programs or long-term care centers, is it was the final time that funding was done by the federal government to build these rural hospitals. Most of them began as nonprofit, and they may have sold by now or partnered into some other outpatient program. In the 1950s, Truman did an attempt to fund healthcare for the elderly, dialing back his program from comprehensive healthcare to can we do something specifically for the elderly, but that also failed to pass Congress in 1951. Another interesting turn of events in the mid to late 50s was the opportunity for employers who offered health insurance to have tax incentives, which basically means that any contribution they made to an employee's health insurance was tax deductible or non-taxable. That still continues today, where an employer gets a tax write-off for offering health insurance. But if you purchase insurance directly as a consumer, you do not get to deduct it from your taxes. So it's a benefit companies have for their employees that individuals do not have today. Because of those incentives, more and more employers began offering health insurance. And because we had almost 40 years of complete failure by Congress to pass anything similar to what we see in Canada or the UK or other organized countries such as Germany and Scandinavian countries, we have really created in our country a private insurance system built through where you are employed. It's important to know how that grew to come about, and these are the beginning processes of what made that happen. Also during the 1950s, the Joint Commission on Accreditation was formed to improve quality of healthcare through hospitals choosing to be voluntarily accredited. This was on the heels of the Hill-Burton Act, which was building all these hospitals. The Joint Commission formed to try to measure quality across locations so that consumers and businesses would know how quality differed from location to location. Finally, in the 50s, the military program was enacted. They called it at the time military Medicare, but it was basically to provide government health insurance for the dependent of those in the armed forces. And that continues today as a separate program for those in the military and their family, but that was created in the late 1950s. That's how that came to be. In the 1960s, President Kennedy in 62 addressed the nation on Medicare in a speech that was televised from Madison Square Garden, appealing to all of the US citizens that the need for offering health care to everyone as a basic right for being a citizen in the US. The American Medical Association issued a televised rebuttal to his plea because, again, they did not feel that a insurance plan that covered everyone was in their best interest, and President Kennedy was unable to get that address prior to his being assassinated. When Lyndon Johnson was made president after Kennedy's death, he signed Medicare into law, providing comprehensive health insurance for individuals aged 65 and older. This was the first significant piece of legislation to happen in healthcare. Prior to this, individuals might be offered health insurance through their employer or may not. In the 50s, we had seen that grown, but there was really no organized governmental program prior to Medicare being formed in 1965. Just on the heels of that, about 8 to 9 months later, Medicaid was also formed to cover those for the poor and the disabled. And so by the mid-60s, we had both Medicare being formed, while it took a few years to implement, and Medicaid for the poor being formed. During the 60s, we also saw a boom in the number of employers offering private insurance because the large degree of press that Medicare and Medicaid through their formation received created a real bit of social awareness of everyone about health insurance. Individuals only wanted to work for companies that would offer health insurance in the 60s. And as a result of this, we saw a large growth in employers then offering healthcare. The final act of the 60s that really helped in rural communities was the funding of these federally qualified health centers that were called neighborhood health centers at the time. But we continue to have federally qualified health centers all across rural America today that receive subsidies for their work so that those in underserved areas can get health care. Many of those are run by a nurse practitioner with a physician that visits, a certain number of hours per week, but it does provide a degree of healthcare in rural America that had not existed before. In 1968, just on the heels of Medicare and Medicaid passing, one of the most significant companies to form that would become a pioneer in the for-profit side of healthcare was Hospital Corporation of America. Pictured here in this image in the center is Jack Massey, who had taken two other companies public, Kentucky Fried Chicken, and later he would take a company called Mrs. Winters public. He was an accountant in his late 50s, early 60s, and pictured on either side of him is Thomas Frist, who just recently retired as board chair. He was in his late 20s at the time, and his father, Thomas Frist Sr., and the three of them were the original founders of HCA. The reason I point this out in the presentation is this is the first time that there had been a legitimizing of a for-profit model in healthcare. Prior to this, most every hospital in America was either a nonprofit formed through a charity, like a religious charity, or a county-owned facility. HCA brought a different type of feel and innovation to its hospitals and began to raise the bar of what competition would look like. It was the first time there was actually even a thought of competition among hospitals, because most communities were grateful just to have one. By the end of 1960s, because of Medicare and Medicaid, we also saw a massive shift towards specialty physicians. And we crossed the line in the 60s, and a majority of physicians then began to trend more towards specialty work than primary work. And the drop off of medical residents choosing primary care began to dramatically accelerate. As you all know, that has continued even to today, where today only 1 to 2% of medical residents choose primary care, and 90+% of all medical residents are choosing some sort of specialty or subspecialty as they graduate medical school. That's why in our country today, largely, our primary care delivery system is led by nurses and nurse practitioners. In the 1970s, Medicare expanded to include end-stage renal disease and those with permanent disabilities. Though those with disabilities do have to wait a 2-year waiting period from the time of being disabled to qualify. The 70s also brought in a new type of support called SSI, which stands for Supplemental Security Income, to individuals. It provides cash assistance to the elderly and disabled who live at or below a certain level of income. Another massive piece of legislation that really enabled employers to begin to think about self-insuring is the ERISA law that was passed, which stands for Employee Retirement Income and Security, exempted employers who chose to be self-insured from all state health regulations. Now that is significant because every state up until this point could decide at their local state legislature what was required for coverage, and the insurer must comply with that. So as a result, if, for instance, my state, the state of Tennessee, said that 30 visits of chiropractic care had to be covered, every employer and insurer in the state offering insurance had to cover 30 visits of chiropractic care. By passing this law, employers who chose to be self-insured were completely exempt from any form of state insurance regulations and only had to comply with 1 or 2 federal regulations. For employers who crossed state lines or had employees in multiple states, this reduced significantly the complexity of being self-insured. If you had employees in multiple states up until this time, you basically would always choose to buy from a health insurance company because they had already figured out all the state regulations and requirements. With the passing of this law, employers could self-insure. They could even manage and pay their own claims if they wanted to and not need an insurer as their partner. So it created an opportunity for a new model to emerge, in that business model that grew out of that in the 70s. It's called the third-party administrator, or the TPA. And today at Shore Capital, we have a company, Point C, in our portfolio that is a collection of third-party administrators, many of which were the genesis formed out of the ERISA laws. In the very late 70s, President Carter attempted to address healthcare costs. He wanted to make some interesting measures and put them in place for reining in this escalating cost of healthcare, but he was unable to do so. The 80s brought the Federal Budget Reconciliation Act, called OBRA 81, which required states to make additional Medicaid payments to hospitals who served a disproportionate or larger share of low-income patients. These were largely either rural or academic teaching centers, and so this notion of disproportionate share, which if you do study the history of healthcare, you will see come often, is a piece directly out of this legislation in 81. And it meant those facilities providing care to the poor and underserved would get a little bit of additional federal support as compared to those who did not. In 85, Congress also passed COBRA, which allowed a worker to keep their health care for up to 18 months past loss of a job. Now, the employee who was losing the job had to continue to pay out of pocket for that coverage. It wasn't required to be paid by their employer, but the employer was required to continue to offer it, extend it, and administer that for the employee. It's a way for individuals changing jobs to have a safety net. A third piece of legislation passed in the 80s was EMTALA in 1986. And this federal legislation required hospitals to stabilize emergency cases regardless of their ability to pay. It's kind of a dark time in healthcare when you had academic centers, for-profit and nonprofit, and hospitals, if you didn't have insurance, would often refer you to an academic center or a county hospital down the street if you didn't have insurance. EMTALA simply says if you were in active labor, bleeding that could cause death or active loss of limb, the hospital was not allowed to transfer you at all until they stabilized you from that emergency. DRGs, diagnosis-related groups, were also implemented by Medicare CMS. CMS was then called HCFA in 1983. Now let's talk about the significance of this because I'm about to show you an example. Prior to 1983, hospitals would charge on a unit basis for every single item you used, whether that was a Band-Aid, an IV bag, a suture, whatever it might be. I remember this period of time because in 82 and early 83, I was interning with a hospital at HCA. And our nurses would walk around with these stickers all over their uniforms that they would have to go put these barcode stickers on the patient's chart so we could add it all together, decide what the patient owed or the insurer owed. This change eliminated the per unit model of business models in hospitals and set up a bundled cost for the admission. Now, often people say to me, well, our federal government isn't very innovative, but this was actually quite innovative. And later, this was followed by every private insurer choosing to do the same. And today, virtually all private insurance companies have modeled their hospital payment system after what CMS Medicare did in 1983 through these DRGs. In just a moment, I'll show you how these model out and what this means. Later in 1989, CMS also set a standardization of how physicians were charged. Up until 89, physicians would submit billings based on whatever fee they wanted to charge for something. And after a 3-year period, CMS would set a rate for them. Insurance companies would negotiate by code for each item on a CPT list. And by using this new relative value units, it allowed both Medicare and all private insurances begin to pay physicians differently as well. So the late 80s brought a massive change in the business model of how hospitals and physicians are paid. Now let's take a closer look at each of them so you can understand why this is so significant. So on the left, far too small for you to read, is the major diagnostic categories of all human health. And there are basically 25 named categories. And then we have 3 sort of other categories where things are either ungroupable or fit into. So for instances, MDC number 1 is diseases of the nervous system, whereas number 2, MDC, is diseases and disorders of the eye, and so on. The numbers next to those are the DRGs, and we have DRGs now going through 999. There's actively about 977 DRGs today, but there are placeholders for future ones to come. So DRGs are diagnostic groups that sit inside these major diagnostic categories. So for instance, down at the middle part of the chart, if you look at MDC number 13, major diagnostic category 13, is disease and disorders of female reproductive system. And within those codes is all types of deliveries that a hospital might do. Take a look at the sample on the right side of the screen. so that you can get a sense of how this works. So I have listed here for you 6 different types of admissions: a normal delivery, childbirth, a cesarean delivery, a hip replacement, an intracranial hemorrhage, which is a type of stroke, a liver transplant, and a neonate, a premature infant born requiring ECMO for breath support because they cannot breathe on their own. Notice the weight. Each DRG gets a weight about its complexity. So for instance, you can see that a cesarean delivery, and this is based on a normative inpatient of 1. So a cesarean delivery is slightly less complex than the average hospital admission, because if the average is a 1, a cesarean delivery is a 0.9561, whereas a normal delivery is less complex than that at a 0.57. An intracranial hemorrhage, that type of stroke, is a little more than 2 times complex as compared to the normal hospitalization. A liver transplant is almost 9.5 times more complex than the average hospitalization. And a neonate requiring ECMO is 21 times more complex than the average hospital. Every hospital gets a base payment. Each October, Medicare assigns every hospital that new payment rate. That allows Medicare to adjust how it pays any given hospitals, not just on nationwide trends like inflation, but also any regional trends and norms that are out there. So the way a hospital gets paid is the base rate times the weight. So for instance, in this example of a $6,000 base payment, a hospital will be paid $3,400 for a normal delivery, $7,500 approximately for a hip replacement, and $56,600 and some for a liver transplant. And every hospital in America gets a slightly different rate, but it's all public domain data. If you ever want to see what these rates are, you can go to cms.gov and look at every single one of the weights and every single one of the base payments by hospital, and you'll know what Medicare pays each hospital. Now, the reason this becomes so significant to our discussion today, it's important to understand when we are offering products that we are selling to a hospital, or we're trying to offer things that support a hospital system, it's important to know that most all hospital inpatients are paid on this method, and all private insurers do the same. Now, private insurance on average is still paying almost double the Medicare rates for hospital services. I'm often asked, well, why are private insurance paying twice what Medicare pays? It's because they don't have quite the leverage that Medicare does. Medicare is 50% of all hospitalizations. Medicare sets the rate. A hospital can choose to participate and get all those patients, or they can choose not to participate and get none of those patients. And so every hospital in America chooses to participate. So on average, the hospital payments are about 199%, but these range from 141% to about 259%. And in some markets, that can be as high as 300+%, particularly in a market where there's only one hospital and they may have negotiated rates with private insurers far higher. Now, the sad reality is the person who pays the most, or who actually gets billed the most, are those without health insurance altogether, and they get paid they get charged the rack rate, which if you ever visit a hotel and seen a rate listed on the back of the door, it's the rack rate that nobody pays. And so that's why you're always shopping hotels.com or something else for a lower rate. And so most individuals want to either get their access through an insurer or Medicare, Medicaid, so they can have a reduction in their payments. I have one more screen that I'd like to show you to compare these. This is from this past year. The Medicare rates are in blue. Each dot represents the 25th, the 50th, and the 75th percentile of the rates. And then the orange represents what private insurers are paying for that same service. So look at DRG number 207, which is a respiratory with a ventilator of more than 96 hours. Now, I point this one out in particular because you will see its variation is so crazy wild as compared to the others. And this has to do with COVID-19 and the number of people that were put on respirators, the short supply of respirators that existed out there, and the vast array of support needed to take care of those individuals with protective equipment. And you can see the 75th percentile of patients on ventilators. Private insurers were paying 5 and 7 times what Medicare paid for the exact same thing. And then some of the others are listed down to give you a point of comparison. For hospitals, the only payer who is rogue or different than this model is Medicaid. Even today, Medicaid pays a per diem for the most part, which is a fixed rate per day for hospitalization. Now that's begun to change in markets where Medicaid is in a managed care model, but largely in a non-managed care model, Medicaid has been paying on a per diem rate for about 20 years. The physician payment that changed is through a resource-based relative value scale. Now that's a mouthful that says, in the very same context of how hospitals were paid, what is the relative value of what you are doing as compared to something else? So for instance, suturing a wound is far less complicated than a surgery procedure, as you can imagine. So every one of the work units that a physician does has a relative value. So there are 3 components of relative value. There's the work itself, and the work RVU has a rate tied to, how complex what the physician is doing is. There is the practice expense RVU. This is what accounts for things like medical supply, office supplies, administrative staff. Cost of living in the market might be a nice way for you to think about it, and it has a relative value weight by market. And then a malpractice RVU, which accounts for how much malpractice risk is in that specialty to give you a total RVU. And then there is the GPCI, which is the market basket for that market. And it lets you know then for this particular CPT code, what a physician might get paid. So let's look at the orange one. It's a little easier to read. And we're comparing a Manhattan hospital to a Beaumont, Texas hospital for CPT code number 52317. You'll see that in Manhattan, the facility code for that particular DRG would be, that CPT would be $396.65. At the Beaumont Hospital, that would be $311.75 by the time it's all done. The non-facility represents the physician. The facility fee represents perhaps facility charges that are associated with it. For physician services, private insurance pays on average about 143% of Medicare, but that may range from as low as 118% with an insurer that has very big negotiating leverage to as high as 200%. There can be much higher rates in some markets for specialties that are really rare or scarce, and it's often set by the negotiating leverage someone has. So as we think about, particularly in healthcare, what is our fee schedules across our SHORE portfolio, and can those fees be raised? It all has to be done in the backdrop of understanding this is the fundamental payment system behind it. Almost every insurer in America pays on some multiple of Medicare. So once you know what Medicare pays, anywhere from 90% of Medicare to 200% of Medicare, even though it's a very wide range, gives you some sense of what you can expect payers are likely in, and where you fall in that range largely depends on your location, the scarcity of what you offer, the quality that you're deemed to have, and your negotiating leverage. We have an expert here in SHORE that works with us, Christy Batuli, and if you want to learn more about this, you should definitely talk to Christy. She's our resident expert in some of these payment models. In the 1990s, OBRA required state Medicaid programs to begin covering children between 6 and 18 that were living in families that was at or below their federal poverty level. This was implemented by one age per year, starting with age 6 through 18, so that the children at the time would continue to have health care. And that took a while to get in place, and that really never was fully realized until the early 2000s, but now exists as part of Medicaid. Also in the 1990s, President Clinton drafted healthcare reform plan that would guarantee basic healthcare to everyone. It was defeated by Congress. He also signed a number of Medicaid waivers that allowed states to introduce managed care in their state programs. It was through one of those waivers that Tennessee formed TennCare, which was done through a waiver program with Medicaid. HIPAA was passed in 1996 that limits employers' ability to exclude pre-existing conditions for employees. It also included certain privacy rules for individuals' protected health information as well. Now, as you can tell, that's dated some time ago, and technology has changed dramatically, and it's a key issue even now in Congress is how to update some of those privacy concerns. Congress did take a portion of Mrs. Clinton's plan, and in 1997, the State Children's Health Insurance Plan, or SCHIP, was formed to really ensure that children in America had access to immunizations and basic health care, regardless of their ability to pay. Also in the late 90s, Medicare Part C was formed. Now let's talk about what A, B, C, and D mean. It's kind of like the same way we name hurricanes, except A, B, C, D represent a different benefit in Medicare. So when you hear the word Medicare Part A, that means hospitalization. So Medicare Part A covers hospitalization for Medicare patients. Medicare Part B, as you can probably guess, covers physician services. Medicare Part C was the introduction of Medicare Advantage plans, and it was the law that began the migration toward the privatization of Medicare from a federal government program to what will likely in our lifetimes become almost a completely private system through Medicare Advantage, where a federal government simply pays insurers a fixed amount to manage Medicare patients through a managed care health plan systems that is highly privatized. In the 2000s, the Medicare Modernization Act, led by Tennessee's own Senator Frist, added Part D Medicare, which covered drugs. And it was then the first opportunity for seniors to have drug coverage as part of their Medicare plan. It also created tax-deferred HSAs, health savings accounts, and paired those with high deductible health insurance plans. And so the beginning of high deductible health insurance plans, many of which our consumers have today, began in 2003. This was the movement away from stated deductibles and copays, whereas individual would have $100 or a $200 deductible, to individuals with what we call high deductible, where they're paying the first $3,000, $4,000, $5,000, and even today, often $7,000 and $10,000 out of pocket before their health insurance pays anything at all. President Bush also expanded the number of community health centers serving the medically underserved, which added more community health centers into the rural markets because hospitals were getting now to be 40 years old. Many had been converted to long-term care centers, shut down, and weren't really serviceable at all. And we had to find some way to offer some degree of outpatient care in rural America. So 2003, because of the high deductible insurance, we really saw the rise of consumer-directed health plans, whereas this direct-to-consumer advertising took off with these high deductible plans and direct consumer plans, and various derivatives and emulations of healthcare insurance began to form. This dramatically changed the job of almost every health insurance regulator in every state, because many states allow for various interpretations of what health insurance actually means, and it created a proliferation of hundreds of types of of derivatives of health insurance beyond the top 4, 5, or 7 carriers we all know today. Now, they still command large market share, but we have everything from medical savings groups to all kinds of things that call themselves health insurance today. And that is highly dependent on what each state allows. Also in the late 2000s, we saw the growth of Mental Health Parity Act, which required insurers to treat mental health conditions, including substance abuse, on an equal basis with physician conditions. Prior to that, most of the time, mental health had an absolute limit on what any insurer might pay. For instance, I had a policy in 2002 that my coverage for mental health or substance was limited to $5,000 a year. That was not uncommon in 2001 and 2002 because mental health and substance abuse was considered an afterthought in 2001 and 2. So the Mental Health Parity Act brought onto same footing of physical conditions, mental health conditions, and that began the growth of the mental health marketplace and behavioral health marketplace we see today. After his election, President Obama implemented and through both houses of Congress signed the Affordable Care Act in 2010. This extended coverage to millions of uninsured Americans. At the time of its signing, we had about 21 million people in the US with no health insurance whatsoever. There are 4 different caveats of this one that I think are worth mentioning as you think about business models in healthcare. First is a number of states had the opportunity to expand Medicaid with deep federal subsidies, and it allowed the poorest to be covered through these Medicaid expansions, going from poverty or 110% of poverty all the way up to 137% of poverty. Unfortunately, my state did not expand because every state could choose to, and it's largely a decision of the state legislature if they wanted to take those federal dollars or not, because the federal government would pay for like 98% of total costs. But Tennessee chose not to do that because it was enacted largely by a Democratic president. Those who did not have access to affordable coverage through their jobs were able then to purchase coverage on health exchanges that were formed. And health exchanges grew that allowed individuals to purchase directly from an exchange. And you can look online and see the millions of people today that are getting your health care through a health exchange on the open marketplace. The third, and one I think is the most significant, is health plans were then no longer allowed to deny coverage for people for any reason, including their health status, nor could they charge more because of your health or gender or a pre-existing condition. This is significant because quite often someone who had had a cancer were almost uninsurable even after their cancer was in complete remission because they had had that before. So there was a lot of leeway taken by some players in the health insurance market over pre-existing conditions. This eliminated the ability to deny someone health insurance based on their condition. The other thing that has helped dramatically is young adults then had the option to be covered under their parents' plan up to age 26. And we saw a massive number of young people who had largely gone bare with no insurance continue to be covered under their parents' plan to 26. A footnote here, just so you know, is from 2012 to 2021, there were 73 attempts to repeal or eliminate key provisions of the Affordable Care Act in Congress. And while some things have changed, it is largely still intact the way it was done. And now, almost 10 years later, it has become the norm and expected and would be very hard to take away from the American people now that they've had 8 to 10 years to enjoy more expanded coverage. So far in the 2020s, the business models that are impacting how we access and deliver. And after this slide, we're going to look at some very specific business models. The COVID-19 pandemic forced providers and payers to fully embrace telemedicine and digital expansion. Congress passed temporary legislation that allowed that support to cross state lines. Previously, You could not be a physician in Tennessee and provide telemedicine service to someone in Kentucky unless you went to get a Kentucky license. And Congress suspended that temporarily, and that continues to be temporarily suspended to allow greater access to telemedicine. As so far in the 2020s, the consumer's out-of-pocket spending has approached now $400 billion. That has created a powerful new marketplace in a traditional business-to-business model. And now business to consumer is significant in healthcare when you think of consumers are spending about 25 to 30% of total healthcare costs out of pocket. This is largely driven by these high deductible plans that most people have. We've also seen in the last 2 years, technology firms beginning to heavily invest in partnership with traditional healthcare firms to make healthcare mobile on your phone, highly responsive, using AI and expanding video and telemedicine even more than we ever imagined. The past 2.5 years have also been a rapid expansion of merger and acquisition transactions, and private equity investing has reached record levels over the last 2 years. The final and a bit disappointing of the last few years is COVID-19 really shone a light on the enormous disparities and gaps in health equity across income levels. It showed how small the middle class was, how prominently growing the underserved was, and the pandemic really highlighted that for all of us, and work is underway now to address that. So now that we've looked at that history, let's do a summary of the business models as they exist. So healthcare prior to 1965 was what we call a transactional market. Consumers and their families were the buyers, physicians were the sellers. Hospitals really had very little prominence prior to 65. In fact, there were typically places you went to die, and physicians were largely in control of the system. You know, if you lived in an urban market, you might buy healthcare with money. If you lived in rural Mississippi like I did, you may barter healthcare for goods and services because you had no money. We did that a lot with our county doctor. That began to change from a buyer-settle model to a three-sided model with the growth of health insurance. And so what you have is between the insurer and the patient in a healthcare market, all the financing rules of what is a premium. Now that premium might be paid by your employer or you out of pocket. The insurer then sets payment rules with the doctor and the hospital. And then between the doctor and the patient, we have access rules. When can you access and who? For instance, you might have to have a pre-authorization to get a surgery. We would call that an access rule. You might have to go to a certain doctor on the list to get fully covered. That would be an access rule. A payment rule for a provider to an insurer is if you do not bill it on a CPT code, we don't pay you. So you have to use a CPT code for your billing. So that is the broadest design of the business model. Now let's dig into a couple of the individual ones. So for Medicare, its business model works like this. Congress defines the coverage, and through the federal government agency under the Department of Health and Human Services is the Center for Medicare and Medicaid Services, or CMS. CMS pays a fixed administration fee to insurers to administer Medicare. So most providers send their Medicare bills to a Blue Cross plan or some private named plan that a Blue Cross or an Aetna or an Anthem might own, or United. The hospital provides services to the senior. They have copays, deductibles. A defined benefit is there for the senior. Medicare Advantage allows those private payers who are doing that form of Medicare to offer additional support. And then those hospitals submit their bills to that administrator, who then pays them the lion's share of their funding. Those small amounts are collected directly from the patient. So in the traditional Medicare model, CMS doesn't pay any claims directly. Those are partnered with different insurance organizations throughout the country who administer on behalf of Medicare those claims. You notice the risk in both Medicare and Medicaid, where I have the black risk angle here, is set with the state or federal system. Medicaid is pretty much the same, except that the state legislatures then set an administrator for Medicaid with the approval of CMS. Now, CMS did something very clever, and that is it created guidelines for Medicaid organizations to follow at the state. And that was because early on, states created their own rogue rules, and all 50 states had 50 flavors, and she had a completely different way Medicaid happened everywhere. So over the years, what happened is HCFA, then CMS, provided matching money to the state if they followed a set of federal rules. Now you can imagine if for every dollar you create in your state, you're getting a federal dollar. If you're willing to follow a set of rules, suddenly everybody started following the rules. And today most states get about half of their money or more through a federal match because they follow a set of federal rules, but they do have a health insurer who administers for that state's Medicaid program, and it works very much like Medicare, and it's designed for those living at or near the poverty line. There is a third business model that ties Medicare and Medicaid together. We call this class of individuals dual eligibles, and it's because they qualify for both Medicare and Medicaid. That means that they are disabled or elderly, because you have to be disabled or elderly to qualify for Medicare, and they are very poor, living at or near poverty. That combination typically is the most complex medical cases we see. They're usually the most fragile and the most expensive. And so managing dual eligibles is a very significant challenge for any insurer, and there are specialty companies that work very hard to do that type of work. Now, when an employer is looking to buy insurance from an insurer, you notice the risk model I have here has shifted over to the side for the insurer, whereas it was on the other side with the federal government or the state. So an employer decides what they want to offer and what they're willing to pay, and they set in place a policy with an insurer around which they will create a premium. And they then share that plan with their employees, who provide them coverage options, and employees typically pick, based on how much they want to spend every month, version A, B, or C. And then they get to seek care from hospitals and other providers who then bill the insurer. The thing I want you to remember about this business model is the employer has decided up front how much they want to cover, and they choose from a variety of options, the insurer, what they want in their plan and what they're willing to pay. One of the biggest myths in our country is consumers still perceive their insurance company may not want to cover something for them, and they're making arbitrary choices of what they cover or not. In fact, most all the time, if an insurer is not covering something, it's simply because your employer didn't buy that for you. Because employers decide up front how much of everything they want to buy and to what degree they want to buy it. So it's a myth that I hope continues to change as we have more discussion about healthcare, because if an employer is buying from an insurer, they knew exactly up front what they're buying. That's why their premium cost is set the way it is, and it's rarely the case that an insurer would not be delivering exactly what the employer purchased. Now let's look at the self-insured model. The self-insured model, you'll notice the risk is not with the insurer, the risk is with the employer. So employers who choose this model they will take entire risk for their population. They will often buy reinsurance, some level of protection once their costs reach a certain level. But then they will contract with an insurer or a third-party administrator like Shore's Point C, TPA. They are exempt from state laws and regulations, so the employer can pretty much decide what they want their benefit plan to be. And then our TPA administers that, and it works pretty much the same way as the private insurance, but the key difference and exception is it's entirely design driven by the employer, the TPA, and the insurer in a partnership with a broker of what you might want to offer your employees. And we're seeing a large movement of employers to this self-insured model so they can exempt themselves from state regulations altogether. So employers who have employees across several states typically choose this model as soon as they can. Now, as I wrap up this presentation, here are a few variables I would like you to consider as you think about the various business models in healthcare and how funding happens. First, the total Medicare Advantage enrollment is dramatically growing. The Kaiser Family Foundation predicts that this is the year that the majority of Medicare becomes Medicare Advantage, meaning more than half, and it will continue to grow over the next decade. My guess is there will be a point at which most individuals who have Medicare will be in a Medicare Advantage plan, which is a privatized form of Medicare administered by an insurer. That is a dramatic shift because those insurance plans can choose networks of who they want to contract with. They can open their own primary care sites. And so you would need to contract with a Medicare Advantage plan, just like you would with Blue Cross, Aetna, or anyone else if you wanted access to this population. So I think that is a dramatic sea change over the next 10 years we should expect to see. The second is, where has Medicaid expanded or not? Typically, the most favorable reimbursement of Medicaid is in the darkest blue states. Medium reimbursement is in the lighter blue, and the most challenged are those in the gray that did not expand their Medicaid, and so they have a gap of uninsured, or they pay very modestly because they have not expanded their program at all. In Tennessee, one of the side effects of our not expanding is we have had 12 of our rural hospitals close in the past 4 or 5 years because they simply could not sustain themselves on what Medicaid in Tennessee paid and the uninsured and the Medicare, because it had so much of their younger population leave the county, and new enterprises and businesses were not coming there. So there was not a growth at all of employers buying insurance, or any employer that was self-funded. The shifting workforce is another item I'd like you to consider. The silent generation has completely left the workplace. The baby boomers, like myself, we have a little bit of time left, but you can see there's not a lot of us left in the workplace. Gen X is fairly flat and has begun to decline. The largest number of folks in the workplace today is the millennial. And most millennials self-search for what they want. They prefer text over human interaction. And coming up behind them is Gen Z, and Gen Z will be quickly replacing Gen X in the workplace over the next 36 to 60 months. So we have a whole workplace now of individuals who prefer technology-driven tools over telephone and traditional advertising. And that is why our healthcare marketplace is changing so dramatically, is those who are entering the workplace choose very much technology, and those who are going into Medicare are largely choosing Medicare Advantage. In fact, the only folks staying with traditional Medicare typically are the very old, as we call them, but those who are new Medicare recipients and qualified new typically choose one of the Medicare Advantage plans because of the additional perks they get. So they're in a Medicare sort of managed care system. You can see here how many employers are shifting to self-insured, even with tiny workforces as low as 40 people. About 15% of those employers are self-insured. By the time you get to 200 plus people, it's a little over half. And then beyond 1,000, it's almost exclusively self-insured. Okay. The reason folks go self-insured is they get a dramatic savings right up front, because the premium taxes, the profits, and the reserves that the insurers take are immediately there for the employer to use, either to enrich the benefit or provide some additional support for their employees as they do that. One of the key cost challenges we have going forward is, if you look at these first two numbers, This is 5% of the people, 1% in this first column, and the 2 to 5% here. That 5% of people in most health plans make up 50% of the total cost. There are 50% of the folks in a health plan that only make up 3% of the costs. So the trick, and why we're seeing so much new artificial intelligence coming into the healthcare space, is every insurer and larger employers alike and consulting houses are looking for all kinds of AI tools to help identify who is in this top 1 to 5% spend, and what we do to have early warning systems that they need help and support. The final thought I'd leave you with as we wrap this up is that physician employment is also climbing steadily as a part of this. The rate of employed physicians between 19 and 20 grew from 62 to 64%. We should see numbers in April for 21, and I expect it's going to grow another 2 to 3% up near 66% or so. We know that for the most part, 70+% of physicians are in an employed model today that are in primary care, and that is growing, and we expect most primary care doctors will be in an employed model by the end of this particular decade. So I hope this has been helpful to you to give you some sense of both the history, the models that exist, and some of the intended and unintended consequences of that. And if you ever want to talk about it further, let me know. We can do a follow-on session where we can talk about some of the particular principles around these. I think that my takeaway is largely this. If you look at the last 100 years of legislation, we should never be surprised of how healthcare works in America, because our Congress tends to do things that seem right at the time, and they are largely driven by public opinion at the time. Secondly, insurers are dealing with thousands of rules and regulations that have come down over that hundreds of years, trying to organize that in a way. Thirdly, employers are looking to be self-insured, and our TPA models, those third-party administrators, ours being Point C, is a fantastic way for employers to self-insure and hedge their risk if they would like. And then finally, we can expect more and more physicians to become employees of systems. Today, the largest employer of physicians is United Healthcare. Aetna quickly follows them, and then hospital systems follow them. So we're seeing more and more physicians either joining a multi-group, and we at Shore have several multi-groups we have helped organize, becoming employees of a hospital, forming their own multi-group with that isn't backed by private equity, or becoming part of an insurer. That trend will only continue over the next 4 to 5 years. Thank you all very much for joining me. Please send me any questions or comments you have, and I look forward to having another session with you. We'll talk even more about all this. Thank you all very much.